Hello friends, this is Nishant Gautam, Associate Professor from the Department of Pharmacology. So today we will continue the same chapter, Fibrinolytics and antiplatelet drugs. Today we will study its last, third part belongs to the unit 2 Pharmacology of Drugs acting on cardiovascular system. Let us start with the next topic of this chapter is the antiplatelet drugs. Antiplatelet drugs are also called as the antithrombotic drugs. These are the drugs which interfere with the platelet function and are useful in the prophylaxis of thromboembolic disorders. Now, let us start the study of antiplatelet drugs by the mechanism of its primary hemostatic plug formation. The primary hemostatic plug formation by the platelets can be made understand with the help of this simple diagram. As we already discussed in the previous class about the platelet activation and aggregation. In that, what we studied, let us summarize the headings like there is a change in the shape of the platelets takes place, then there is a release of the calcium and ADP from the platelet granules, then the receptor activation of the platelets takes place, which are the two receptors. The glycoprotein 1b binds to that of the 1 bilirubin factor leading to the adhesion. Then the glycoprotein 2b and glycoprotein 3e complex leading to the aggregation by the collagen. Then let us discuss about the role of cyclooxygenase over here. We can understand with the help of this chart. So just focus this receptor. What happens here? The PAR1 and PAR4 are the protease activated receptors that respond to thrombin 2A and promotes the platelet aggregation and the secretion. Further, here P2Y1 and P2Y12 that we discussed in the earlier classes, here what they did, both of these P2Y1 and P2Y12 are the receptor for ADP. When stimulated by agonist, these receptors activate the fibrinogen binding protein, glycoprotein 2b, glycoprotein 3a, and cyclooxygenase 1, COX1 to promote the platelet aggregation and the secretion. This platelet adhesion, activation, and aggregation can also be made understand with the help of these 5 steps. Here, with the help of these 5 steps, in this diagram, it is clearly shown how the platelet adhesion, platelet activation, and the platelet aggregation taking place after there is the secretion of COX1 and the release of the ADP, and with this, the conformational change of the glycoprotein 1b and the glycoprotein 2b and the glycoprotein 3a, and also the 1 bilirubin factor, how helping the platelet adhesion. Now let us start in detail about the step in the platelet activation and aggregation. Also with this we will study about the site of action of antiplatelet agents. Let us discuss each and every step one by one. The first step. In this first step, the resting platelet is there, that is the discoid in shape with the glycoprotein integrin 1b, that is the 1 bilirubin factor. Then the GP 2b GP3A fibrinogen receptor, thrombin receptor, ADP receptor, that is the P2Y12 and thromboxane receptor. And in the second state, a stimulus such as endothelial injury causes the thrombin release and wall-Willibrord factor interaction with that of the GPI-B. Resting platelets changes their shape from discoid to spherical. Thrombin binds to its receptor, resulting in increase of COX-1 activity, thromboxane and ADP release from the platelet granules. Then, in the third state, what happens? The ADP and thromboxane bind to their receptors and increase intracellular calcium and CAMP. Intracellular CAMP levels are maintained by the phosphodiesterase enzyme. Then, what happens in the fourth state? The platelets are activated and the glycoprotein integrin B and 3A undergoes a conformational change to allow the fibrinogen binding. Then finally, in the fifth state, what happens? The platelet aggregation occurs with cross-linking of platelet along with fibrinogen. Uremia alters all these steps in that it reduces the expression of GPI-B, limits intracellular calcium and CAMP increase, and hinders the GP2B and 3A activation. The site of action of aspirin, clopidogrel, and these drugs are also shown here in this state. The same platelet adhesion, activation and aggregation can be made understand with the help of this simple diagram where we can see the coagulation cascade, platelet activation and aggregation with that of the normal position of the platelet and it's exposed to subendothelium and also with this the ruptured plaque. What happens? The platelet expresses the several glycoprotein integrin receptor on their surface. Reactive protein like collagen are exposed when there is damage to the vascular endothelium and they react respectively with platelets GPIA and GPIB receptors. This results in the platelet activation and the release of the pro-aggregatory and vasoconstrictor mediators like thromboxane A2, ADP and 5-HT. The platelet GP2B and GP3A receptor undergoes a conformational change and favoring the binding of fibrinogen and von Willebrand factors that cross-links the platelet including aggregation and anchorage to the vessel wall or the other surfaces. Thus, a platelet plug is so formed. In case of vein, due to the sluggish blood flow, a fibrinous tail is formed which traps RBCs, the red tail. But in case of the arteries, the platelet mass is the main constituent of the thrombus. And the antiplatelet drugs are therefore more useful in the arterial thrombosis, while the anticoagulants are more effective in venous thrombosis. The prostacyclin PGI2 synthesized in the intima of the blood vessel is a strong inhibitor of platelet aggregation. A balance between thromboxane A2 release from platelet and PGI2 release from vessel wall appears to control intravascular thrombus formation. Platelet also play a role in other activities and the atherogenesis. Now come to the different class of the antiplatelet drugs. They are classified as the first class is thromboxane A2 inhibitors, that is the aspirin. Second class is the ADP antagonist, that is the ticlopidine. Then the clopidogrel and the ticagrelor and the cangrelor. The third class of this antiplatelet drugs is the phosphodiesterase inhibitors, that is the dipyridamole, silostazole, and the fourth class of the antiplatelet drug is the glycoprotein 2B 3A receptor antagonist is abscisimabe and the FIBBRINOLYTICS and the tirofiban. So here we can understand by this diagram the different targets for the antiplatelet therapy. The different class of the antiplatelet drugs has their different site of action. For example, the ADP receptor antagonist get bind with that of the ADP receptor. The drug is clopidogrel, whereas the phosphodiesterase inhibitors like dipyridamole interferes with the signaling pathway, and whereas the fibrinogen receptor antagonist inhibits the binding of fibrinogen with that of the conformity changed GB, 2B and 3A receptors. On another hand, the aspirin non-steroidal anti-inflammatory drug inhibits the cyclooxygenase 1, which further inhibits the production of thromboxane A2, which helps in the conformational change of the GB receptors or the glycoprotein integrins. Whereas the thrombin inhibitors inhibits the thrombin receptor through which it interferes with that of the activation of the platelets. So here I summarize the different targets for different class of antiplatelet drugs which we are utilizing therapeutically. With the help of this diagram, we can easily understand the mechanism of action of different class of antiplatelet drugs. This antiplatelet drugs inhibits the platelet activation, aggregation and the platelet adherence. For example, see at the center of this diagram in the red format the platelet activation shown. This platelet activation is responsible for the formation of cyclooxygenase. This cyclooxygenase is directly made inhibited with the use of the cyclooxygenase inhibitors like that of the aspirin. Further, this cyclooxygenase is in presence of the thromboxane A synthase made the thromboxane A2. This thromboxane A2 get bind with that of the thromboxane A receptor, which also made inhibited with the help of the thromboxane A receptor antagonist like the teribuprol. Further, this platelet activation is made inhibited by the increase in the CMP. So, this increase in CMP takes place due to the action of the epoprostenol on the prostacyclin receptor, which helps in the increase in the CMP, which inhibits the platelet activation. This increased CMP also agonize with the help of the phosphodiesterase inhibitors, for example, dipyridamole. On another hand, this platelet activation is also responsible for the production of ADP, which further get bound with that of the ADP receptor, is made inhibited with the help of ADP receptor inhibitors. Also, we can say the P2Y12 receptor inhibitors. And the example to inhibit this drug is the clopidogrel, palisogrel, and ticagrelor. These drugs inhibit the ADP receptors. Further, this activated platelet is responsible for the activation of the alpha 2B and beta 3 receptor, which further responsible for the binding of the fibrinogen, so that the attachment with that of the another platelet takes place. So this binding of the fibrinogen is made inhibited with the help of FCC wave and the tirofibine. Another choice of the drug is the thrombin inhibitors, which acts on the PAR1 and the PAR4 receptors, which we made already discussed in the previous. Here, the example of this is the bivalirudin and the dabigatran. So, like this, the different class of the antiplatelet drug targets the different site for the platelet activation and its action. Now, let us discuss the antiplatelet drugs one by one. So, first we will discuss about the aspirin. Aspirin is a cyclooxygenase 1 inhibitor. In platelets, major cyclooxygenase product is thromboxane A2, which is a labile inducer of platelet aggregation and potent vasoconstrictor. This aspirin blocks the production of thromboxane A2 by covalently acetylating serine residue near the active site of cyclooxygenase. This enzyme produces cyclic and peroxidase precursor of the thromboxane A2. So, what happens since these platelets do not synthesize new protein, as the action of aspirin on platelet is permanent up to 7 to 10 days. Further, this aspirin shows the complete inactivation of the platelet cyclooxygenase 1 is achieved with the daily aspirin dose of the 75 mg. Now, the question arises, higher the dose, more efficacy? The answer is no. If we will increase the dose of the aspirin, so what happens at the high dose, 1 gram per day, it also inhibits the COX-2. So it is responsible for the synthesis of prostacyclin, which is a potent inhibitor of platelet aggregation. Now, the therapeutic use of the aspirin. The aspirin used in the prevention of the acute myocardial infarction in the patient of the unstable angina. In the prevention of reinfarction in the patient of acute myocardial infarction and ischemic heart disease. In the prevention of the stroke in the patient of cerebrovascular accident and the transient ischemic attack. Also used for improving prognosis in patients with atherosclerotic peripheral vascular diseases. In the percutaneous angioplasty for the coronary thrombosis, and also used in the primary prophylaxis of thromboembolism in patients with the prostatic heart valves. Another class of the drug is the ADP antagonist, that is the ticlopidine. Ticlopidine blocks the GI coupled ADP receptors. Ticlopidine is a prodrug which is activated by hepatic cytochrome P450 that inhibits the P2Y12 receptor by forming a disulfide bridge in the extracellular region of the receptor. The ticlopidine shows the rapid absorption, high bioavailability, maximal inhibition of the platelet. It takes 8 to 11 days after starting the therapy. The adverse effect of ticlopidine is nausea, vomiting, diarrhea, neutropenia, thrombocytopenia, and the uses of this class of drug ticlopidine is in the prevention of the cerebrovascular events in secondary stroke, unstable angina in the combination with that of the aspirin. In the combination of the aspirin used in the angioplasty, coronary artery stenting. The another drug is the clopidogrel. It is a newer and more potent congener of ticlopidine, has similar mechanism of action and having the ability to irreversibly inhibit the platelet function and range of therapeutic efficacy, but is safer and better tolerated. It is an irreversible inhibitor of the platelet P2Y12 receptors. Further, it is more potent and has a more favorable toxicity profile than that of the ticlopidine. The genetic polymorphism can cause the resistance of the CYP to C19, whereas the usual dose is 75 mg per day. Loading dose may be given. The recombination of clopidogrel plus aspirin is the superior to aspirin alone. The two drugs are synergistic to each other. The another choice of the drug is dipyridamole. Dipyridamole inhibits phosphodiesterase as well as block uptake of adenosine to increase platelet CM, which in turn potentiates the PGI2 and interferes with the aggregation of the platelet. The level of thromboxane A2 and PGI2 are not altered, but platelet survival time reduced by disease is normalized. Then this increased CMP level by inhibiting cyclic nucleotide phosphodiesterase takes place like involved in the metabolism of the CMP. Further, dipyridamole is a potent coronary vasodilator. The another important choice of the drug is the glycoprotein GP2B3A receptor antagonist. These GP2B3A antagonists are a newer class of the potent platelet aggregation inhibitors which act by blocking the key receptor involved in the platelet aggregation. The GP2B3A is an adhesive receptor integrin on platelet surface for fibrinogen and the von Willebrand factor, through which agonists like collagen, thrombin, thromboxane A2, ADP, etc. finally induce the platelet aggregation, and thus the GP2B3A antagonists block the aggregation induced by all platelet agonists. Further, the glycoprotein 2B3A is a platelet surface integrin. Then the drugs belongs to this class is the abscizimab and the aptifibbatide and the tirofiban. Now, the GP receptor antagonist drug is abscizimab is the Fab fragment of a humanized monoclonal antibody directed against the A to B beta 3 receptor. This drug also binds to the vintromactin receptor, which facilitates the adhesion on the platelets. vascular endothelial cells, and the smooth muscle cells. The patient undergo percutaneous angioplasty for coronary thrombosis. We are using this drug to prevent the restenosis, recurrent myocardial infarction, and death in the conjunction with that of the aspirin and the heparin. The therapeutic use of this drug is in the coronary artery disease, in the acute coronary syndromes, to treat cerebrovascular diseases, and in the prosthetic heart valves and arteriovenous stent, and the venous thromboembolism, and in case of the peripheral vascular diseases. So that's all for the day, and today we finish this chapter, and we will continue the next chapter of this unit. Till that, have a nice day and thank you.